Oh.
Okay.
I just did a wonderful introduction, and I have to do it all over again. I apologize. This is Brad DeCamp with Ohio Mental Health and Addiction Services, and if you're here for the Maternal Opiate Medical Support informational webinar, you have come to the right place. We're going to do introductions here of folks in the room, but I would like to do just a couple of quick housekeeping items. First and foremost, we are going to be recording the webinar. So if you have other colleagues or other partner agencies that were not able to be on the webinar at this point in time, we will record it and put it out online probably early next week. We will have the phone lines muted. As we go through the PowerPoint, we will open the phone lines after we are done. And if you have questions during the course of the presentation, would ask that you type those in at the on the question box, which hopefully will be on the right side of the screen as you see it. So before we go any further, we'll just do real quick introductions of who's here in Columbus in the room, and then we'll ask Dr. Mark Hurst if he'll make a few welcome remarks, and then we'll get going. So Dr. Hurst, if you wouldn't mind doing, we'll go around and do introductions.
Yeah, I'm Dr. Mark Hurst. I'm Medical Director for the Department of Mental Health and Addiction Services.
Janice Franke in the legal office of the department.
Matthew Loncarrick in the Bureau of Health Integration.
Rosalind Gatewood-Ty in the fiscal area of the department.
And Rick Masadi with Quality Planning and Research.
Okay, so with that, I would ask Dr. Hurst if he would like to make any opening comments.
Just very briefly, I want to reiterate Brad's welcome to everyone. We are very pleased and gratified that so many people have shown an interest in this project. We think that this is a project that is very important for the well-being of opiate-addicted women and their children, and think that we can make good headway on this project over the next couple of years. I've spoken with a number of you over the past few months with this, and it's very satisfying the way so many groups have gotten together to collaborate on this, and many of you have told me that, funded or not, you plan to proceed with this project because you recognize its importance, and if nothing else, this project has served as a motivator to get people together from the addiction field, the obstetrical field, and the pediatric area. So, we're very pleased with this. Thank you for your interest, and we look forward to reading your applications in a few weeks. And now I'll turn it back over to Brad for an initial presentation before we open it up to questions and answers.
Thank you, Dr. Hurst. Also want to acknowledge Matt Loncarrick. Matt is going to be helping us navigate and also address the questions as we move forward, as will the rest of the team, but Matt is actually manning the laptop as we speak. And towards the end of the presentation, the PowerPoint, we'll also have Rick Masadi, who's here, who introduced himself, who will talk about the evaluation criteria that we're going to be using to go through the responses to the RFA. So without any further ado, we'll go ahead and start through the slides that we have. So we can go ahead and move on to the next. Okay. So why are we doing this? And I'm going to, some of these slides will be text heavy, so I will try to kind of paraphrase and move through them as best we can. But Ohio Mental Health and Addiction Services, through the Office of Health Transformation, is making innovation funds available to accomplish the following overarching goal, which is to improve fetal outcomes, improve family stability, and reduce the cost of neonatal abstinence syndrome to Ohio's Medicaid program by providing treatment, including medication-assisted treatment, to pregnant mothers during and after pregnancy. So that's the broad purpose of why we're making the funding available. And then we have some primary objectives that are attached to that. There are 5 of them. I'm not going to go ahead and read through all of those. Waiting for the slides to catch up on the computer here. Hang on just a second. There we go. So again, I'm not going to read through all of these, but again, what we want to do is develop the concept of an integrated medical maternal care home and look at providing access to treatment both for women while they are pregnant and after they have delivered their baby. And that will include medication-assisted treatment, also looking at obstetrical services, and then also developing a protocol which we will test and evaluate at 2 to 3 sites across the state. And our overarching thought about one of the things with sustainability is that we will generate enough savings in Medicaid by reducing the length of stay in the neonatal intensive care units to really offset the cost of the project that we have for M.O.M.S. Let's talk a little bit about expectations. Again, this is one of those text-heavy slides, so I won't go through all the bullets. But again, what we were wanting to see is, in terms of general requirements, is that we would want to see services that are provided with the appropriate language and cultural context that would be appropriate to the population. Gender-specific substance abuse and other therapeutic interventions to be provided to at least 75 women, and included in that would be trauma-informed care when appropriate. So just to kind of spend a little bit of time talking about this one, and I will make it brief, but one of the things we would expect is that we would want to see at least a target of 75 women. So that's kind of the baseline for that. We also talk about therapeutic interventions for children in custody of the women, and again, focusing on trauma. Also looking at case coordination, case management, to ensure that women and their children have access to these services. And also, I'll just jump down a little bit, but looking at really enhanced collaboration with children's services, criminal justice, vocational rehabilitation, and employment services, and other entities that would serve Medicaid-eligible consumers. So I'm not going to go through all the bullets on this. Certainly, it'll be available for you to look at afterwards, but those are kind of the key points that I would emphasize in terms of our expectations. In terms of funds and funding availability, we're looking at a total of, or just about an approximate total of $1.89 million over a 3-year period, and this would be beginning in the second half of state fiscal year 2014, so the current fiscal year. We would ask that the applicants would be required to identify other funding sources and amounts, and this would include Medicare, self-pay, insurance, so on and so forth. There have been some questions that have come out about the total amount of the grant being different than what was in the press release, and so what I would want to point out is it is projected that Medicaid will pay for approximately $1.72 million worth of services in the project. And then there's also an approximate $600,000 that will go towards evaluation. So if you total those up, you will get to the $4.2 million that was actually included in the press release. So I just wanted to go ahead and go through that just to kind of clarify how that funding is broken out. But again, the M.O.M.S specifically is $1.89 million, approximately. Okay. Eligible applications will be accepted from individuals certified by OhioMHAS to provide addiction services, or entities duly certified by Ohio Mental Health and Addiction Services to provide addiction and mental health services. We've gotten a few questions about who, if you have a hospital or another physician's office, if they are can be the applicant, and what we would say is that if they are in partnership with a certified treatment provider, then yes, that can happen, but we would look for the individual lead applicant to be the certified entity, certified by Ohio Mental Health and Addiction Services. Going through some of the special requirements, the agency must be able to demonstrate a minimum of 2 years' experience in treating opioid-dependent pregnant women, including the use of FDA-approved medications for pregnant opioid-dependent persons and addiction services. There also must be a commitment to work with the local alcohol drug mental health services board, law enforcement, public children's services, your children's services board, and the justice system. And one of the things that we want to do is not only obtain applicants who are experienced in providing the service, but we want to have programs who have good relationships in their community, because as we begin to go through this, we'll definitely hit on some collaborators, and certainly the justice system and child welfare are big partners with that, as well as the local boards. Because we are dealing with medications and we'll talk a little bit more about this in detail as we get further into the presentation, that are controlled substances in terms of the actual medication. We are asking that the implementing agency provide effective controls and procedures to guard against theft and diversion. Obviously, that is a big deal with diversion. There's a lot of areas that are struggling with that, and so we would ask that the applicants address that. We also have what we will be calling a learning collaborative, and the learning collaborative will be really a virtual learning community that will be comprised not just of the applicant, not just the entities that are funded through M.O.M.S, but also those who are interested in learning more about developing effective practices and partnerships between physical and behavioral health care, also working with child welfare and other areas around treatment improvement with medication-assisted treatment. So we will have that expectation as well. We will also ask that the implementing agency, though the applicant that is awarded, is required to establish a business plan that reasonably guarantees sustainability and self-sufficiency. We do ask that you also provide a staffing plan that looks at medical services, treatment professionals, and other key team members who will help the program move forward. But we do want to definitely have a good idea about sustainability and how folks will address that in their applications. The general instructions for completing the applications, again, we want to have this done. I'll try not to read all of this, but it will be a bit challenging. Using Microsoft Word version 2013, or 2012. I guess there isn't a Word 2013, is there? My bad. 2003 or later. And again, what we want to do is basically give some guidance to say that this is the format that we expect the grant to be in. We do not want the narrative section to exceed 35 pages. And again, that does not include the attachments or appendices. We are asking that the applications be submitted electronically to the address listed here in the PowerPoint. And that is, and then later down we also have the website where we are posting FAQs on a weekly basis. So if you've not checked that out, I would certainly encourage you to do that. So the applications need to be received by no later than 2 o'clock on Friday, December 6th. I believe that is 2 weeks from today. My math is correct. And anything received after 2 p.m. Will be considered late and not be reviewed. So let's just go over quickly some key dates, and this will kind of inform you about what we're envisioning our internal process to be. So that we release the guidance on November 8th. Today is the webinar for the 22nd. We will have a question and answer period that will extend through next Friday, the 29th, and then the applications are due on the 6th, as I mentioned, by 2 o'clock. We also have a board review comment form that would be due to the department. So if you're in a particular county and you're submitting as the lead applicant, we would expect a review sheet from your local ADAMHS board to be sent in to the department. We will have review teams that will be meeting and reviewing the grants and then coming to a decision around on or about December 17th. And then we will be notifying the awarded entities at the end of December, December 27th. We're expecting that services to begin on March 1st. And then 2016 is the end of the grant period. One of the things that we do want to emphasize is that it's important to be sure and monitor the website for any updates to the FAQ or any other changes. We're putting some additional information out there as we speak. Well, not right at the moment, but it will be updated very frequently, and we are taking the questions that are coming in and answering those and posting them so that everyone has access to the information at the same time. So those are the dates. These are some of the more legal restrictions for the grant funds. Again, I'm not going to go over all of these verbatim, but for example, we cannot, the grant funds cannot be used to purchase vehicles, cash payments to recipients, capital improvement, construction, professional credentialing fees, license fines, etc. We will also have a standard agreement and assurance form that will be sent out, and would that be sent out at the point in time that we've made the award, Janice?
It would be executed then, but there should be a copy, I think, posted for people to review.
All right. So I mentioned earlier that we do have the board comments, and this is something that we do look at, and certainly would ask that folks be considerate of the board and their process in terms of getting copies to them in a timely manner. This is something that I can tell you that we definitely do look at to see how the board, and hopefully that they have been a partner with you throughout the process, but definitely look at the input that they have on the application as we begin to enter into the review process. So in terms of questions and technical assistance, we've talked about the FAQs. So the FAQs are being submitted to the website, or I'm sorry, the email address here, the OhioMHAS bid opportunity. And that's an email address that is being checked regularly, and then the questions are being forwarded, and we are answering those and then posting them to the website. And there actually is a M.O.M.S section on the web page now that is being updated, as I said, on at least a weekly basis. So let's talk a little bit about the grant application review process. We will have kind of a compliance review that will look to make sure that the general requirements are met. And then we will have review teams that will be formed that will take a look at the applications as they come in. And Rick Mazzotti will talk about our criteria here shortly. We will be looking to check the budget tables and make sure that the narrative and budget amounts all line up, and also be looking at that as part of the process. All required forms must be dated, scanned, and attached to the application as directed. Okay, so there is, and Matt, did you want to go ahead and address the clarification?
Certainly. As part of the questions and answer process, we've received several great questions and responses that we've been able to clarify. And one of them that came in this week was regarding the budget table that we had posted. The budget table that is currently posted and that will be replaced covers only 4 quarters of a grant period, and that's kind of standard boilerplate. But the M.O.M.S project is unique in that it covers a period of 10 quarters, 2 full years, and then 1 full quarter into 2016, and then the month of June. So the revised budget table that you will see on the website beginning next week will cover 10 quarters and make it much more straightforward for you to post your proposed expenditures, and it will help you greatly in your planning.
And this is just an example of the importance of checking on the website to see if there have been similar, if any additional updates or changes get posted.
Okay. Thank you, Matt. Thank you, Janice, for that. In addition to the review process, one of the things that we do as a department is we reserve the right to reject in whole or in part any and all applications to the department, taking into account consideration factors including but not limited to cost and the results of the evaluation process that the department has determined would not be in the its best interest to award. We also, and again, I'm not going to read through all of this, but we reserve the right to make no award, make an award for a lesser amount, make an alternative award for the specified project, or make an award for shorter duration. This could be an area that could come into consideration for the M.O.M.S project because, again, we don't have a definitive amount. We do expect to award a very small number, 2 to 3, but again, depending on how those work out, we may ask the applicant to make a revision to their budget, and so that would be covered here. Continuing on with the review process, the applicant is solely responsible for reporting, withholding, and paying all employment-related taxes, payments, and withholdings, federal, state, and local income taxes, Social Security, unemployment, disability, withholdings, and payments. So, We will have reporting requirements. If you are interested in the particular language about the authority to do that, those can be found on the website below. We will be putting those forward. We have, of course, some of the budget forms and other things that we have already, but then we also have an evaluation section that will be covered here momentarily that will also inform some of the reporting requirements as well, and will be fleshed out as we move forward. Okay, so let's kind of move quickly into the application. We generally have three to four sections. We'll actually have 3 sections that we'll go over here this afternoon. We do have the face sheet. We'll ask you to basically identify the organization, the total amounts of funds requested. Again, just identify, making sure that this is the M.O.M.S project, time period. And then if there comes a point in time where we do need to have a budget revision, there will have to be a signed face sheet that accompanies the revision as well. Okay. So starting into section 2 and 3, this is where we kind of get into more of the meat of the narrative portion of the grant. You will see as we move into section 3, there are numbers off to the side, and Rick will cover this in much more detail than I'm able to, but I want to kind of give a flavor of the weighting of each of the sections. So as we get into section 3, you'll see those numbers and you can see the relative weighting scores for the different sections. But in terms of the abstract, this is something that we would expect to be fairly straightforward. We want basically kind of the high-level information, where the project will be located, the number of individuals served, which medications will be utilized, the types of services provided. Also, it would be helpful to have a brief description for establishing the schedule for opening the site, who your intermediate areas and collaborative entities are. And we do expect this to be about no more than 1.5 pages. So again, this is summary level information of your project as you're proposing it. So moving into the project plan, we have the information about the applicant. This would be helpful for you to describe to us your experience in implementing and operating this type of programming, demonstrating that you have a minimum of 2 years of experience in treating pregnant mothers who are opioid dependent, including the use of FDA-approved medications for treating opioid dependence. We also would like to have for you to describe the capability to fulfill the services required of the M.O.M.S project. For the geographic location and accessibility, I think really what we're getting at here is trying to get a handle on how accessible the services are going to be. It will help us to know where obviously the project will be located, but we also would like to know for you to describe whether or not the provider will have co-located services at the location. In terms of collaboration, again, we talked a little bit earlier about the local alcohol, drug, mental health boards, but we also would definitely expect there to be strong evidence in terms of collaboration with the local Public Children's Services Agency, including any MOUs, Memorandum of Understanding for referral protocols, as well as local health care providers, and that would include family health care providers, obstetrician and pediatrician as well, local law enforcement, also local county Department of Job and Family Services, and access to mutual aid, which would include AA, NA, etc. Okay. So moving on to the staffing description, and on this section, you'll see that there's a pretty big distinction between the weighting. So as we look at getting into sections 3 and F, you'll see that there is more weight given to those particular sections. So I just wanted to draw that to folks' attention. But in terms of staffing, we do want to make sure that the staffing does reflect the racial and ethnic and cultural balance that will be included in the target population. We will ask for folks to submit a table of organization. That would include, amongst other things, how you would be providing a medical director, healthcare professionals functioning under the medical director, and other key staff, including clinical staff and other contractors who would help make a key contribution to the program. As we mentioned earlier, in the earlier section in terms of general expectations, we do in the participant recruitment want you to describe how you're going to, the strategy that you're going to use to provide services to a minimum of 75 pregnant women who are addicted to prescription opiates and or heroin or successfully till the end of treatment. What would be very helpful here is to see a list of strategies such as a sort of outreach, and certainly not limited to that, but that's one suggestion that folks will use to recruit and also maintain people in treatment. Would also be helpful to understand the plan to engage women as early as possible, but no later than the end of the second trimester. And then, if applicable, any information or materials that would be used for participant recruitment and how that would describe their role in their recruitment strategy. Clinical services, let's move into that one. So again, with 3E and 3F, these two are weighted very heavily, so these are important sections, and Rick will talk about those a little bit more here shortly. But basically what we want to get here is a good description of the services that will be available and the levels of care provided, including services focusing on the family as the unit of service, and also services to enhance engagement and retention. Specifically, we would also like to see some attention given to child care, nutrition counseling, tobacco cessation, etc. If you're going to be using a standardized protocol, like a risk assessment, a standardized pregnancy risk assessment for treating cases of NAS, that would be good to have here. Also a description of what evidence-based practices you would be using in the targeted group. This is an important section, so I'm going to just read a few more. Describe how clients will transition into aftercare and receive ongoing services such as post-treatment recovery checkups, regardless of their discharge status, stage-appropriate recovery education, assertive linkage to recovery community resources, and early reintervention into treatment if needed. Moving forward, we have the section on vocational job placement and ancillary services. And again, this is identifying the types of services, who you'll be partnering with, again, within the types of services, who are there going to be, what are specific ancillary services in addition to vocational, housing, education, etc. And then another key piece here will be describing how the provider will monitor referrals to ancillary service providers to ensure that clients are able to access and receive these services. Project plan for success. What we'd be looking for here is to really kind of identify the critical success factors for this type of a project in terms of the size and scope and complexity. We'd also like to hear about any barriers that you have experienced and how you would plan to deal with those. In doing so, we would expect that there would be MOUs with key agencies and collaborators. We mentioned child welfare earlier, but also a key partner, we believe, in this process is the Medicaid managed care organizations, also local public housing authorities, and then mental health services if the applicant is not duly certified. So again, we would definitely encourage folks to be planning for interaction with the Medicaid managed care. Certainly there's a good thought given to the fact that they will play a key role in providing sustainability to this project. In terms of retention, we would like for folks to address specific techniques for how your organization or your partner organizations will use to make sure that participants follow through with the services. We would also ask that folks consider developing standardized criteria that will help monitor retention and indicate how you will know when a client is at risk for disengaging, and then how you would re-engage them in the process. Okay, moving into the monitoring and QI, and then also data collection and quality improvement. In the RFA, you notice especially in the data collection area, there are a number of measures that we listed. And the one thing that we do want to make folks aware of is that To the greatest extent possible, we're going to make sure that that information is collected at the state level. So we're going to try to keep that burden off of the providers and other partner organizations as much as we can. But that's certainly something that we will take on as much as we can. But we will ask, at least, we ask that you in the monitoring section that you will describe to us how you monitor project operations and outcomes. And I think one of the things that we would definitely want folks to describe is how you can use data to very quickly make adjustments to your program and solve problems and meet the project goals. We will have the applicants be required to provide data needed for the evaluation. And just so folks are aware, we are using the Department of Medicaid's Technical Assistance Policy Program, also known as MedTap, to help facilitate the project evaluation. The applicants must demonstrate a commitment to cooperate and collaborate with the both OhioMHAS and Medicaid, and then the selected quality improvement and subject matter experts, including the evaluator, as we move forward. We will be providing a resource online, probably early next week, that is from the Institute for Healthcare Improvement, Rapid Cycle Quality Improvement Model. We'll make sure that that's available for folks to look at so that they have that and can take that into consideration in their applications. Okay, moving into the home stretch here for the project plan section. In terms of the work plan, we have some appendices that are available online, and this is where the resource from IHI we believe will be helpful in terms of developing the key driver diagram. That's where we talk about the description of the primary aim, objectives, key drivers of achieving the aim, and also key project individuals. There are maybe some of you who have previously been part of the NIATEX rapid cycle change efforts that the former Department of Alcohol and Drug Addiction Services had been part of. So if you were involved with that, you might see some similarities in those two resources. We're also asking for a plan or a description of how the project will be sustained, looking in terms of who, the local and regional stakeholders are that will be accessed. Talked a little bit about Medicaid managed care, and certainly that's an important player. And if there's one thing to emphasize, it's certainly to, again, try to reach out and work with the Medicaid managed care folks as much as we can. We do also ask for budget narrative, and this is into the business plan area, and looking at providing how you will address the areas of sustainability moving forward. And again, not just limited to Medicaid, but also looking at other funding sources such as insurance, self-pay, grants, and other areas. We also ask that you will explain how the use of funds will be monitored. Again, this is a 3-year project, so we would like to have a description of how that's going to be handled or from your perspective. And then do include the attachments, and Matt spoke to this earlier in terms of the revised document that will be placed on the website. Lastly, in terms of letters of support, we're asking that you provide letters of support, and I do want to draw a distinction between letters of support and letters of commitment. Certainly, we appreciate the fact that people will be willing to write letters of support supporting you in your application, but there will be certain partners, such as child welfare and perhaps maybe your local county Department of Job and Family Services or courts, that if they are willing to write letters of commitment, which specifically identify steps that they're going to take to help support you in the grant and identify what those actions or steps are, that will certainly go a long way as well. So we do have the opportunity to do letters of support, but certainly it would be beneficial to have letters of commitment as well. So with that, I am going to stop talking and turn it over to Rick Mazzotti and let Rick talk a little bit about, do we have any questions? Do you have any written questions, Matt?
No questions.
Okay. All right. So without any further ado, I'll turn it over to Rick Mazzotti, and Rick will talk about the evaluation, the criteria that we'll use to evaluate the RFA.
All right. Hello, everyone. I hope you're having a good day. I'll be briefly discussing the evaluation criteria for the M.O.M.S project. This is available as Appendix A online, and it should help you understand how we'll be evaluating the proposals in a standardized fashion. There's going to be a small group of people reviewing each proposal, and the scores will be averaged amongst the reviewers to develop a total score per proposal. Again, we'll be using a weighted point system to evaluate the technical criteria, and here on the first page you can see what some of those weights are. The point values we can assign are 0, does not meet, the application does not comply with the requirements, 1, weak, the application does not substantially meet the requirements, 2, moderate, the application meets most of the requirements, however it is weak in some areas, 3, meets, application generally meets the requirements, 4, strong, application exceeds requirements, and 5, greatly exceeds, the application significantly exceeds requirements. Now, we expect a variety of applicants to come in, and some of these may be rated, some programs you have may be rated a little bit strong, or some may be rated a little bit weak, and that's okay. The goal here, though, is to really have a good overall program. Our evaluation criteria follow each subsections 3A through 3P on the guidance for applicants, and if you refer to the very last page of the document, this overall score sheet shows the weights for each of the sections. And it tells you how much detail we want you to include basically in each of the sections. So as you can tell from what Brad said, the two most or highest weighted areas are the clinical services and participant recruitment. And so if I just go to participant recruitment real quick, one of the things that you're going to find is that it may be difficult to recruit pregnant women in your areas. And it's important to partner with enough people in order to get to 75 women. And just to talk a little bit more detail about something Brad said, it's not just that we want to serve a minimum of 75 pregnant women. We want to make sure that these 75 pregnant women are followed successfully until the end of treatment. And so it's really important in your proposal that you think about recruiting more than that, so that by the end of the 3-year period, we have 75 that are followed successfully until the very end of treatment. Other important criteria in the participant recruitment section, for example, are: does the applicant describe reasonable criteria for participant inclusion? What kind of women are you going to include? Are you going to be talking to women of various different racial and ethnic backgrounds? Are there specified recruitment locations that reach the target population? Is there an adequate plan to engage women as early as possible, but no later than the end of the second trimester? And as part of this process, we're also interested in understanding what you're going to do with women who don't meet the criteria for the grant. So here we have a criteria at the very end of this section about women who don't fall in the from the first to the second trimesters, and we want to know what you're going to do to help those people also. Let's see here, for the clinical services part of the program, this evaluation criteria is again the highest weighted part of the evaluation criteria. So we want to know whether the applicant proposes to provide an appropriate array of prevention, treatment, and recovery services and levels of care to the target populations. We want to know whether the services offered are adequately going to focus on the family as a unit of service. We want the applicant to propose to provide or refer women to relevant education or health promotion services, which could include but are not limited to prenatal education services and tobacco cessation services, et cetera, et cetera. So for each of these sections, you can see that things are weighted between 5 and 20, and obviously we want you to spend a lot of time on the sections that are weighted 20 as opposed to 5. I think that's all I have to say for the evaluation criteria.
Okay. Matt, Janice, or Rosalind, did you have anything to add at this point?
I don't have anything right now.
Okay. Raj, good? Okay.
Thank you.
Matt has put up on the screen, and we'll go ahead, since we're not doing too bad for time here, we will go ahead and put the key driver diagram, and this is one of the things that we talked about earlier. So what we're going to do is we're going to make some resource that is put out, I believe, by IHI, that will kind of go through some of their particulars that they do when they use this type of quality improvement science to really help inform and drive practice. And this really is becoming to be used more widely. We mentioned at the very beginning the Office of Health Transformation has been a big partner with this, along with Medicaid and Department of Health and Department of Job and Family Services. But OHT is looking at adopting this particular type of structure to really foster program development. And the ones that are, you can probably see this if you look closely, but the ones that are shaded in the grayish purple are the ones that are primary to this particular project. But again, you kind of get the flow. Actually, for me, it's easier to kind of go backwards to start with the global aim in terms of looking at creating a system of care there at the lower left-hand corner, then going up to the SMART aim and specifically looking at the notion of the 30% reduction in average length of stay in the neonatal intensive care unit, and then what are the key drivers and interventions that are attached to that. Some may go to more than one area, but again, that's kind of the general flow. We had it more of a generic logic model format, but I think after consulting with our colleagues at Medicaid and given the kind of the direction that we're heading with the evaluation, this appeared to be a better fit in terms of how we would like to have a graphical, how this information will be presented graphically. So I will be the first to admit I am not an expert in key driver diagrams. I think we're learning a great deal about it collectively as a staff, and I think through this process we will definitely be in a better position to do that moving forward. But again, this is out there, and we will be putting the additional resources from IHI to help you complete this particular area. So, Dr. Hurst, did you have anything you wanted to add?
No, again, I think that again, we're looking forward to the applications, and we're looking forward to questions, and some of them have popped up, and we're ready to start responding to them.
Okay.
I'm guessing that's MOUs and the letters of commitment be referenced.
Memorandums of understanding and commitment the same.
I think and folks here can agree, disagree, and we can talk a little bit about it, and then maybe huddle and provide a consolidated answer if we don't have a consensus. I think that the MOUs are a little bit more, I would see them as being more specific and perhaps more binding than a letter of commitment.
That would be my assumption, too. I think the MOUs we would be looking for are formalized relationships, forged for the purposes of doing the work of this RFA, whereas the letter of commitment would be signals from community members who recognize the work and are supporting it, but in a less formalized fashion.
Okay, next question, are prescription opiate addicted, I'm assuming women, excluded from this? I wouldn't think so. So I'm assuming maybe there's a distinction between individuals who are maybe using heroin and prescription opiates, but we're actually wanting to have, it's okay for prescription opiate addiction to be included as well.
The third one, can you type in your question?
Yes, we have a comment. Hi, I'm trying to ask a question, but phones are on mute. Yes, if you would rather, we will unmute the lines here in just a moment as soon as we get through this list of questions. Please clarify, can a hospital be the lead on this application I believe the answer to that is if the hospital is certified, they could be the lead applicant.
And Brad, to clarify, by certified, do you mean certified by the department?
Yes,
I'm
sorry.
Having a
by Ohio,
certified alcohol and drug treatment facility.
Or yes, either certified as a addiction treatment provider or certified as a mental health. So one or both, but it would have to be a certification from Ohio Mental Health and Addiction Services. Yes.
Although a hospital could partner with a certified,
yes.
that wasn't
right.
a certified entity could partner with
Correct.
a entity that was.
Next question, I assume that Medicaid claims data will be used to collect costs. Can we send you patient names of participants without HIPAA waivers? We might want to talk about that.
Yeah, I am guessing that there will be a system set up to
yeah.
deal with that. For instance, the
okay. So yes, we'll
we would be getting that information from.
Yeah. Well, let us, Jennifer. Let us. I think we have an answer to that, but let us kind of respond to that one online once we have a chance to run that down a little bit more. Okay, that doesn't look like. It looks like we answered a question, so that's good. If we have physicians currently involved in the treatment of pregnant opiate addicts and want to increase their time on the project, can we use grant money for that, i.e. increasing physician services?
That is an interesting question. I have my lawyer next to me here, so she can hit me if I'm not saying the right thing here. But one thing that is clear is you can't use the funding to supplement Medicaid billings. So Medicaid billings are what they are. However, if you have salaried physicians and you're increasing their amount of time, that would be acceptable, I would think. And additionally, there are physician services that would be necessary parts of this project that are not billable services to start with, such as participation in treatment team, consultation, and things like that. And I would think that would be an acceptable cost as well. Am I on the right line, Janet, here?
Seems right
Janice?
to me.
Okay.
Yeah, generally speaking, as long as you're doing something in addition to, that you're not, trading one thing out for another, but it's clear that you're adding to, it's a value added, I guess would be another way to say it. That's generally okay. Do we use your key driver diagram or develop our own? My sense with that is that there could be some, by and large, probably there will be some overlap, but there might be some specific drivers or interventions at the local level. So I would definitely want you to put your own flavor on that, again, recognizing that there probably will be some overlap. Do we need to address every key driver or just the one shaded in gray? That's a good question. I think certainly we do want the ones covered that are shaded to be part of that. And do we want to consult with?
I would consult with that.
Yeah. Let us. So yeah, let us take that one back, and we'll talk with the folks who helped us develop this to get a specific answer on that.
And I think that question came from Joe Gay. Joe, I think the safest thing to say with that also is the more comprehensive the services, the better. So I know that's a little bit vague, but again, the more gaps that are filled, the better off it's going to be. And I agree with what Brad said about local variation. There are going to be local variations that are going to lead you to want to develop your own key driver diagram, or at least supplement the one that's in place here.
And then looks like we have a budget question. Do we need to present our entire budget along with the portion that will be funded by this grant, or just the portion that will be funded by the grant? And
the way the document is set up, the template, it would be that they would spell out the specifics with regard to the grant funding, but there is a space for them to add the totals, at least, of other funding and revenue sources.
okay, so so obviously Medicaid
And there could be a bit of a
they would,
descriptor put in there.
yes, okay,
But the detail top portion is
just for
relates to the monies received,
For moms.
awarded.
Yes, okay. Could you expand on what prevention refers to? Prevention of opiate use by pregnant women seems like a different focus than the core focus of the grant. Prevention of adverse consequences of use and associated lifestyle. I think that it's probably a combination of I think that it's yeah, that's submitted by Joe Gay, and I do think that we want to have some discussion about different types of prevention services, and again, it may be more of a universal approach as opposed to specific. So my sense would be it would probably be more of the adverse consequences and use of the associated lifestyle.
Yeah, I would look at prevention more broadly.
Yes.
I would look at primary, secondary, and tertiary prevention associated with that. And Joe, since you had the question about is it only the gray boxes, I'll point out that wasn't in a gray box, but that's an important question.
Okay, so we appear to be through the questions that have been submitted on the box. So what we are going to do at this point is we're going to unmute the phones. I would ask that when you ask your question, if you could please state your name and the organization so that we can have that recorded as well. So,
And we'll want to try and take down the precise questions.
yes.
End up posting all the answers.
Right. Give us just a moment. We are experiencing just a little bit of difficulty getting the lines freed up, so if you'll bear with us for just a moment, we'll resume with questions as soon as we can.
Everyone's gone. Just have, if anyone's trying to ask a question and not able to speak, ask them to type it in.
We unmuted.
We're unmuted.
Okay. So we did have an additional question come in. Do all addiction treatment services have to be provided by the applicant? Can some services be provided by an alternative mental health MHAS service provider? Can some treatment services be provided by a non-certified? I think this was an FAQ that we posted. I think if I remember correctly, the services can be treatment services can be provided by another MHAS certified provider, and a non-certified provider can provide non-treatment services. So is that kind of how we had landed on that? Yeah, so ancillary services, non-clinical treatment services can be provided by a non-MHAS certified provider. But if you're going to be providing treatment services, that does have to be provided by a provider certified by MHAS. So it looks like we're having, I'm sorry.
Well, so Brad, so an example of that would be that, again, the regular counseling and all would have to be by a certified provider. But if an applicant was choosing to provide transportation services, again, if they wanted to contract with a non-certified provider to provide transportation, that would certainly be acceptable.
Yes.
Okay.
That's exactly right. So as we have been here trying to figure out the audio, we are not able to turn the audio on to open the lines right at the moment. So what I would ask you to do is go ahead and type questions if you have them in the question box, and we will address those as they come in. I do apologize for the inconvenience.
And don't forget, we do have the ability to submit questions through that email address.
Yes, thank you.
Do we have an intended posting time of the new budget form document?
For the new budget form, we made the request to post yesterday. Usually takes a few business days to get that posted, so I anticipate by Monday.
Okay.
Yep.
So please check that. That will work better for you in putting your budget down.
We'll give it a few more minutes to see if we have any additional questions that come in. And again, just to keep in mind, we have recorded the session, and as Janice had mentioned, to please check the website. We will certainly be posting this recording and the PowerPoint slides as well. Okay. Will the grant pay for housing? If so, for how long? That takes a lot of resources just for a few people. Yes, there is. We do have the ability to pay for recovery support services or non-clinical services that would include short-term housing. So I believe we had, if I remember correctly, well, let me not speculate. Let me just answer that yes, it can be used to pay for short-term housing, and we can provide some additional information as we post the answer. But yes, it can. Yes, there is. If the woman is engaged with a provider that is part of the OhioMHAS Women's Network, which means they receive SAPT block grant funding, Substance Abuse Prevention Treatment block grant funding, that is something that they help take care of as well. So if they're providing residential services, then that will be covered in that particular area. What if housing is not residential based? If you're asking about the grant, yes, we would still cover the housing. I think what we were trying to suggest is that the residential resources do exist for individuals who are at that level of care, so therefore they wouldn't need to have the housing at that point in time. Okay, we'll give just maybe a couple more minutes to see if there's, okay, there's another one. There you go. Can you clarify what information you want inserted in the key driver chart? Should we develop our own key drivers, use one provided? Am I correct that we should complete almost all of the intervention column with the activities we're proposing? I think this was a similar question we had earlier, but I think by and large, again, you're going to be, there will be some overlap between the one that we provided and the one that you will provide, although again, there will be some variation based on your local system. I would expect that there would be, yes, most of the interventions would be with the activities that you're proposing, yes. Okay, I'm unclear on what letters of commitment for managed care Medicaid would say. If we are a hospital, applying the role of managed care would be to pay the bills and submit it and pay possibly for patients. Can you clarify what we'd expect the letter to cover? So the overarching goal of this is to decrease ultimately the length of stay in neonatal intensive care units. So I think that perhaps what we would maybe be looking for is the engagement of a Medicaid managed care organization that would be stating that they would be supportive of a project that would decrease the length of stay and provide better care to avoid additional costs being provided or being brought onto the Medicaid system. And someone is writing me a note, so I'm going to quit talking for a moment. So that wasn't for that. Well, okay, we can provide some additional clarification on that, I think. Is that okay, Jess? Okay. We are concerned that it is difficult to elicit a timely response prior to the due date from our Medicaid managed care providers. Okay. Yeah, we can definitely take that in consideration in the process. So in that situation, would it be okay for them to provide narrative that they have reached out to but may not have been able to hear back?
Yeah.
I think if you were able to, that's from Joe Gay. The other question was from Jennifer. Yeah, I think anything that could help provide that clarification. Can the managed care provider write one that covers all applicants? They would support all projects. Okay. Let us, Jennifer, thank you for those questions. Those are very good, and thank you, Joe, as well, for the question on that as well. I think what would be best for us is to maybe get some clarification from our partners at Medicaid and see what they would suggest, and then we can post that on the website as soon as we get that from them. So I think given the time of the day and since we are kind of, we're not able to unmute the lines, what I think we would suggest at this point is that, and Matt, could you go ahead and pull that slide back up that has the address? Instead of going through the questions here, I think what might be better is to just go ahead and submit whatever remaining questions there are to the email address, and Matt is pulling that up here on the screen. That is the OhioMHAS bid opportunity at mha.ohio.gov. So if you type your question in there, then what we will do is we will record that and then post it on the MHA website as quickly as we can, and we are updating those, as I said, at least weekly. So I think with that, we will go ahead and conclude the webinar. I do hope this has been helpful to you, and we are looking forward very much, as Mark said, to getting the applications in and making an award here before the end of the calendar year. So, Mark, I don't know if you or anyone else has any other thoughts.
But yes, thank you again for participating in the webinar, for your interest, and for helping us with the process as we move forward with it. So we're looking forward to working with everybody as part of this. We will respond to the questions online, and obviously the last question about the Medicaid managed care, we'll clarify that with our colleagues over at Medicaid, and maybe it will make that a lot easier for everybody. So thank you again, and everybody have a good weekend.
Thank you.
Thanks.